I believe that reproductive justice is an indispensable step to attaining global peace, whose realization has been a long time coming. Not only is this a way to attain global peace, it is also a way of providing inner peace. In particular, for women in sub-Saharan Africa, where I come from, these women have been for centuries denied autonomy over their bodies, reproductive health, and their sexuality.
My name is Dr. Tlaleng Mofokeng, and I'm from Johannesburg in South Africa. Reproductive justice means more than just an ability to make choices. Choices and the ability to decide on your life and have autonomy have to be supported by laws and policy that are inclusive. We know a lot of people, whether it's through their gender, through age, through class, or race, or locality, or geographical position of where they are, often are excluded from public health services, are often included from participation and fully, being taken care of within the health systems. And reproductive justice speaks about having societies and communities that can support people regardless of their vulnerability, regardless of what choice they make. And when you're talking about the healthcare system specifically, reproductive justice demands literal access to services that are affirming, that take into account people's human rights to bodily integrity, to dignity, to safe space. And it's only when reproductive justice is replicated through the laws, through program designs, through implementation, that communities and individual people can feel truly cared for.
To me, reproductive justice is about guaranteeing that all women across the world have the ability to exercise autonomy and control over their reproductive choices, whether to have children, when and how many to have, and the ability to care for those children in supportive environments. This means more than just the legal right to do so, which continues to be a barrier in many parts of the world, but it also means true access. In Guatemala, for example, we have a law guaranteeing universal access to contraception, but in practice, we see that 1 in 3 Indigenous women has no access to reproductive health care. The reproductive justice framework challenges us to identify all the barriers to access for all women, which often include issues like little to no sexual health education, geographical barriers, cost barriers, cultural barriers, and unsupportive household members, as well as fear of government institutions.
Does reproductive justice mean to me? For me, is a safe space where every person, especially women, have the freedom to enjoy the rights of deciding by themselves if they want to have kids or if they don't want to have kids, when to have them, and how many they should have. So they have teach us, and we have in our minds, doctors and providers, that we have the right to decide for them, or that they don't have the knowledge and the experience to decide. But that's not true. We should work in teaching them, especially our women, to decide what they want in their lives. So for me, that is reproductive justice.
Hi, my name is Khadija Khan, and I am the International and Muslim Youth Advocacy Manager at Advocates for Youth, a national and international sexual health and reproductive rights nonprofit that focuses specifically on young people. To me, reproductive justice means access to a safe, healthy, and affirming world. It means being able to give ourselves the permission to be in touch with our bodies, in touch with our body's needs, in touch with our body's histories, and the information and education to make informed decisions, as well as to have full autonomy over those decisions. And it's not just about our own bodies, it's about our communities as well. It's about young folks, it's about our elders, it's about queer people, it's about disabled folks, and so much more.
Girls and women who come from economically disadvantaged backgrounds are the ones who have inadequate access to sexual and reproductive healthcare. In Zimbabwe, we have limited healthcare facilities, and oftentimes these are distributed along socioeconomic lines. People who live in low-income areas tend to have limited access to these facilities. And also, it so happens that these are the people who need these facilities the most. There's geographic barriers. Zimbabwe is kind of divided into rural and urban areas. And so people living in rural areas live far away from healthcare facilities. And as a result, they also have limited access. Zimbabwe is largely a patriarchal society. And so oftentimes you have men coercing women not to seek these resources because they believe that once women gain an understanding of their bodies, they will then gain autonomy over their bodies. There are also other factors that come into play, mainly religion, socioeconomic status, and geographic barriers. And with religion, we have, for example, the White Garment Apostolic sect. They don't advise their women and young girls to go and seek healthcare facilities because they generally just don't believe in medicine. In terms of socioeconomic status, again, it's all about, can you afford the resources? Education has been a way of emancipating women from patriarchy. And so once women get educated, they can now get a job. And once they have a job, they then attain economic independence. And through that, now they can afford reproductive healthcare, and at the same time they can now have a say over what they want to do with their bodies, how many kids they want to have, if any. If a woman is not educated, she's mostly living under her husband, or if it's a girl, it's like under her father. They have to live under the rules and the regulations of these men. Their reproductive health rights are then in the hands of these men. That gives the men room to regulate their access to sexual and reproductive health rights.
People who often lack access to sexual and reproductive health and rights are usually people who are vulnerable, people who are marginalized either by their gender, their sexual orientation, people who are differently abled. You've got people, again, who have comorbidities of illnesses, right? Where young people are born with HIV, and a lot of the prevention message around HIV, around sexual transmission, often leaves them out. You have people who, because of where they find themselves geographically, it becomes really hard when you are in a rural area or a peri-urban center to be able to access services. Sometimes a lot of money has to be spent on transportation just to go from one province or one state to the other, trying to access services. The bias sometimes in medicine when it comes to the conditions that people seek help for. If you are a person who's requiring a safe abortion, we know the obstacles that are often in your way, whether it's stigma, whether it's religious or cultural, resistance, whether it's issues of affordability. So I think sexual and reproductive health and rights and access to these services really give us an opportunity to look holistically at our programs and to really ask ourselves how much of what we are doing is bringing closer, or at least centering, these people with a certain vulnerabilities and marginalization.
When we think about who lacks access to sexual and reproductive health care, first we can think about all those who lack access to healthcare in general. That tends to mean poor communities, rural communities, and generally disenfranchised populations. When we look more closely at sexual and reproductive health care services, we see other factors begin to complicate access. For example, adolescents tend to have fewer options for where to receive confidential care. Many places require that they receive care only with the consent of their parents. LGBT communities tend to have very limited access to providers who are trained in and fully understand LGBT sexual health. Here in Guatemala, indigenous communities are particularly marginalized in access to any public services. And where government health facilities are available, they're often not utilized because of generations-long distrust in the government and experiences of racial discrimination in those facilities. In addition to this lack of physical structures, access to healthcare workers, and this experience of discrimination, we see even more reasons why access is more difficult for indigenous communities in Guatemala. For example, extremely low education levels make it hard for patients to understand the care they're receiving and to advocate for themselves in a healthcare setting. Guatemala has 24 indigenous languages, many with regional dialects that are not mutually intelligible. This makes it extremely hard for every speaker of these languages to have access to care provided by someone they can effectively communicate with.
Are those more marginalized because of where they live, sexuality, religion, social or political position. It's something that can happen at a national level. It's much more easy that these kind of things happened with very poor people in rural areas, and especially with indigenous people who don't speak Spanish. It's more difficult to them to access to quality services. It's difficult to them to get to the services only because where they live, sometimes there are not good roads. It's only 20 or 40 miles, but it takes them maybe one day to get to a service because roads are extremely bad, or they don't have money to transport, or there is no public transportation. Another one is language. We have a lot of languages in Guatemala, and what makes it more difficult is that even the same language can be talked different from one town to another. You can say you speak Quiche, but maybe you speak the Quiche from here, another one from here. Another important one is the lack of education that brings a lot of myths and fears. So people think that IUDs will give you cancer, or that your baby is gonna be born with the IUD here. So there's a lot of course, myths that they're not true, but people are afraid and they don't come to the services because they believe in those myths. Another one very important is sexism, because women are not allowed to decide for their own safe and health, and most of the times the husband is the one who decide, or the mother of my husband. So we saw a lot of times that we asked the patient, when was your last period, the date of your last period, and they tell us, I don't know, can you please ask my mother-in-law? So we have to ask the mother-in-law.
So at Advocates for Youth, I run a program called the Muslim Youth Leadership Council, which is a group of young queer, trans, and allied Muslims from across the country. And this program exists specifically because it is so difficult for young people. Add on the layer of being a young person who's Muslim, add on the layer of being a young person who is queer and Muslim, makes it so much more difficult to have the access to sexual health and reproductive rights that we really need. The reason for this is there's a lot. Both internally within our communities, there's a lot of silence and stigma when it comes to discussing topics around sex, which is true for many, if not most, communities. But then we have the added layer of external Islamophobia that exists in mainstream spaces that make it harder for us to access culturally responsive healthcare, culturally competent LGBTQ spaces as well. And yeah, so there's definitely a great need, and our young people are working hard to address that. I always say in America, in this country, none of us are starting from a great place. Many places in the country, most, don't have comprehensive sex education, and even then, oftentimes, it doesn't include information about bodies who may be different, bodies who may work differently than most folks, bodies that are queer, bodies that have specific religious and cultural backgrounds and present in certain ways. And in general, no one's really starting from a great place. There are certain cultural stigmas and stereotypes and racism that impacts people's ability to access comprehensive sex education.
Entre los principales retos que las comunidades indígenas de Guatemala deben enfrentarse al momento de buscar servicios de salud sexual y reproductiva, podemos mencionar la falta de información efectiva. Dicha información debe estar basada según las necesidades de cada individuo para poder garantizar una toma de decisiones libre y consciente. El escaso acceso a los servicios de salud, principalmente en áreas postergadas del país, que conlleva a las familias a tener que invertir más tiempo para poder llegar a estos servicios, afectando así un día laboral y por ende a largo plazo afectando la economía familiar. La escasez de personal calificado para brindar ciertos servicios, principalmente en áreas de difícil acceso, Y cuando se tiene la presencia de este personal, muchas veces no domina el idioma materno de la región, afectando así la buena comunicación. El machismo sigue siendo una de las barreras principales, dado que el hombre sigue siendo el único en la toma de decisiones y en casos más extremos, la familia del hombre es quien toma las decisiones importantes de pareja. Las creencias religiosas que desembocan a darle importancia a mitos que a largo plazo limitan el acceso a los servicios de salud.
Well, I think there are multiple. First of all, the lack of quality services and qualified providers, the barriers of language, economic difficulty, and of course, sexism. I think these are the main problems that they can find.
The steps that are necessary to ensure that marginalized groups, such as people living with HIV in countries like South Africa, it's to ensure that, we realize that comprehensive access to healthcare truly means that comprehensive. We cannot decide what's more important for people and make those judgments and those decisions even reflective in policy or the laws. It's important that funding also matches the need. We cannot fund in little pockets or work in silos and miraculously expect that people will feel truly cared for. I think the problem, as it is with many countries in the global south, is that we know the impact of the global gag rule means that unfortunately those NGOs, those governments, those projects that receive federal US funding cannot give people information around safe abortion. We can advocate for sexual rights. We can advocate and then hold our own governments accountable for their lack of, services around safe abortion. You may very well, have young people who want information about HIV, but they are pregnant. They don't want to be pregnant anymore. And you find that a state facility denies them that service. And that's where the injustice is. It's the fact that a lot of the vulnerable communities, a lot of young people, for example, young women with HIV who need services in the public sector, cannot be guaranteed that when they go there the first time, they are going to get the service that they need. They are going to get a health professional, that's trained. So I think what we really, really need is to focus on training, is to focus on access that's inclusive, and to focus on laws that are supportive.
At Wings, we work hard to ensure that our clinics are accessible to marginalized populations. This is our mission, and it's our reason for existing. We do this in a number of ways. First, we bring our services to the patients rather than asking them to come to us. By providing mobile services and partnering with community hospitals across the country, we're able to reach more rural populations. When patients have trouble even getting to our mobile services, we often coordinate and pay for transportation to get them to us. Whenever we provide services in government facilities, they're completely free of charge. When we provide services outside of government facilities, we ask for a small donation, for example, $3 for an IUD. But if that small donation presents a barrier for a patient, we're always willing to provide our services free of charge. And adolescents always receive our services at no cost. Given the nature of our work, the cultural taboos at play, and the cultural diversity across Guatemala, it's also key to our success that we recruit nurses, doctors, and field educators from the communities that we serve. We know that our work is better received from someone who deeply understands the local culture and context. When possible, our staff provide care in the local language. And if that's not possible, given the vast linguistic diversity across the country, we make sure to coordinate ahead of time with a community partner who can translate for us. At Wings, we continue to work to strengthen our ability to serve the LGBTQ community. Last year, we included trainings on LGBTQ sexual health in each of our week-long quarterly staff trainings, and we'll be continuing that work this year. We've partnered with a local trans men's collective to help train our staff and analyze how to make our services more accessible to trans men. In this way, hoping to successfully receive and care for the patients that they refer to us. Our staff that work in our youth-friendly space receive the most questions about sexual orientation. They often provide counseling to teens who are questioning their sexual identity or trying to navigate whether they can safely come out in their homes and their communities. Our staff have partnered with a number of other community organizations that are even more specialized in providing holistic support for these teens, so that we can often provide warm handoffs when our teen patients are interested in access to these other services.
How do we ensure that our clinics are accessible to marginalized populations like low-income indigenous Guatemala? Well, almost all of our services are provided for free, and there are a few places where we ask for a small donation that actually is a symbolic donation. It's not the real cost of the service. If somebody cannot give that donation, we don't ask for money. Nobody should leave our service without receiving what they want, only because they don't have money. That's something that we repeat constantly to our teams. It's important. People sometimes don't have any resources. They should not be denied what they decide that they want.
There are three things that can be done. Firstly, providing the services at an affordable cost, increasing access to the services through setting up facilities in resource-limited settings. Finally, education. And this is something that I myself have tried to do. I set up Mwanasikana, which is a grassroots project that is aimed at raising awareness of sexual and reproductive health rights in high schools in marginalized areas in Zimbabwe. And this is just a way of having conversations with girls and women about their sexual health and their reproductive health rights. And this is how I came to find out that most women, like 50% of the women living in these areas, have a limited understanding of these rights. And so I believe that just educating all the women as well as the men about these things, and also just ensuring that these facilities are available to them, would be a great way to provide comprehensive sexual and reproductive health care.
So when it comes to folks around the world being able to access reproductive rights and healthcare, a program that I really want to share with you all is something called Amaze. You can go to www.amaze.org, and it's a series of short animated videos for very young adolescents and young people that really answer questions that people have, that young folks have. Everything from understanding my body parts, to what is masturbation, to how do I understand my gender identity. And they're done in these really cute, short animated videos that I think really help open up parents' minds, but also young folks' minds. What's amazing about Amaze videos is that we have translated them into so many different languages all across the world. There's an Amaze Latin America, Amaze for East and Southern Africa, and the list goes on. And so you can find all that information on YouTube and check out our different programs and different adapted videos. But I have personally seen, working in the international space, how impactful those can be for creating community conversation. There's parent guides that go along with them, and being a really helpful, easily accessible resource to answer some, important questions.
I think it's important, to have the discussion about the role of healthcare providers and what they can do to offer equitable services. I think it's important, for healthcare providers globally, but more so in environments where politically it gets increasingly difficult to really be inclusive and comprehensive in what we offer because of restriction in funding. I think it's important for healthcare providers to be, aware of the language they use in consultation, is to really push forward the idea that safer communities mean that healthcare providers ourselves need to advocate for those. We are really still held in very high regard in many communities. And one of the ways that we can advocate for people who are vulnerable, one of the ways that we can show the benefit of having services that are more inclusive, is to us to be the voice. We need to speak up for those who it's not safe for them to speak up, for those who, for example, may still be criminalized in the communities where they live in. But as healthcare providers, our role is to advocate. Our role is to take care of each other, is to form networks, is to provide those spaces where we can debrief, and more importantly, be strategic in how we can use medicine and the healthcare system in itself as a tool for change, as a tool for justice. And we can really only do that if we ourselves have the support we require from each other. Unfortunately, some of the support we can't rely on other networks, but ourselves and each other. And I think that's why it's important to keep the networks going, to keep ourselves coordinated and strategically, wherever we are in the world, walking this journey and working towards a more inclusive world and society. I think the issue of human rights is important. Medicine is not devoid of rights. And if we can use medicine as a tool to advocate for human rights, that would be really, really a big step to ensuring that we really end discrimination. But more importantly, we use medicine as a quest for justice.